extremely interesting for us. So residents, don't be shy. Seniors, please share your experiences, and yeah, let's start the discussion.
So let's start from us. If you permit. I really appreciate your presentation and the difficulties what they have, especially with the bone setters, the gangrenes happening. And in India, in 90s, the condition was almost same. From villages, patients did not reach the hospital in bone setters. So we have gone through this journey, and last 3-4 decades, we have progressed to this thing. What are your opinion of starting, a sort of a pre-hospital trauma care? That is very important, and I don't think that is existing here in Ethiopia or any African countries where we can chip in there.
One of the things that we've managed to do in Ghana with the traditional bone setters is there was a group of surgeons who were very interested in developing an educational material that was aimed at preventing the preventable complications of traditional bone setting, as well as establishing a referral pathway for traditional bone setters to refer patients to the hospital. So we involved, there was a lot of leadership even at the level of certain areas in Ghana. We recruited the leaders, the traditional bone setter leaders. We recruited, geolocalized them. We developed the curriculum it took us about 6 months to backwards plan, do the competencies that we thought. So we developed around diagnoses, treatment of what they can treat, refer what they can't treat, medical records, pain management, and ethics. But you have to pay for this. So you have to invite them to a session. And right now we've been able to run 5 of these sessions in Ghana. We're trying to do the same thing right now in Tanzania, in the northwestern part of Tanzania. So rather than taking the stick approach, taking the carrot approach. It's still not perfect. Even in Ghana, I was there about a month ago, and we were doing one of these educational sessions. And during the course of the 4-day course, there was an emergency powwow because a young girl had fallen at school, and she sought the treatment of a traditional bone setter. She had bilateral undisplaced distal radius fractures, and she's now got very high below elbow amputations. And the question now was what to do next. The family, the boss of the traditional bone setter local chapter wanted to bring this guy up on criminal charges. But the family did not want to do anything because of this spiritual belief that if they anger this traditional bone setter, that they will be cursed for life. So he was brought in for a little bit of a little fireside chit-chat, but it's still a problem. It's still a problem. I think it's still a problem in India as well. And they're not going to go away because there's just not enough of you. And there's not enough of you to take care of all the problems. And there's not enough money also for people to be able to access what I would call orthodox orthopedic treatment. Sorry for the long and windy response.
Thank you. In India also, it's slightly there now. It is mainly in the periphery, in the tribal areas, hilly areas. This bone setter problem is still there.
Okay, thank you. My question for Dr. First of all, I'd like to say thank you for your enlightened presentation. So my question is, what is the role of 3D printing machine? The role of 3D printing machine in using robotic assistant.
3D printing also is coming in a big way. Especially, it is very important in understanding and getting custom-made implants also with 3D printing. It is very important in especially hip surgery, and when you require, let's say, a particular deformed acetabulum, you have to replace, or you have to have a bone defect planning. Then that is the time when 3D printing is of great help. And there are a couple of companies in my city of Pune who are actually giving us a 3D printed implants also in difficult situations, especially in acetabular side. It's very important. In knee surgery, 3D printing has a very limited role. If there is a deformed sort of a bone, for example, in a huge bone defects due to neglected long time disease, or post-traumatic, especially post-traumatic arthritis. If there was a trauma with a, say, depressed medial or lateral condyle fracture, which has got rotated, then to implement, get implant right in that, 3D printing will be of a great help. But 3D printing, then augmented reality, virtual reality, and as we were talking, in coming days, now I am also working on a project of AI. AI also is going to come in after robotics. The next step is going to be artificial intelligence. So I think the science is just going to go leaps and bounds now, no limit.
Thank you very much for your insightful presentation. This is for Dr. Narendra.
Thank you.
We see from your presentation that robotic surgery is having this complication, less time consuming, and rehabilitation process is very fantastic. Again, thank you for this insightful and eye-opening presentation for us. So my question was, like, how is the affordability of this procedure compared to the traditional way of robotic surgery? Some people afford for it, or is there a system which covers the cost to do it for every patient? Thank you.
Actually,
you can also add this. Joint replacement in Ethiopia is still at its infancy, so it's not something that we can easily, make available for the whole patients that need it. So, how much of your joint replacement percentage is robotic assisted, and what are your actual cases that you would need it, and is there actually a clinical superiority in routine knee replacement? You can, with the post, you can actually elaborate this.
yeah, regarding the affordability, basically the costs in India for knee replacements are really very less as compared to, say, Western countries. I'm not exactly sure what are the costs in Ethiopia, but they are very affording. And we don't charge anything extra apart from the disposables which we have to use for this, especially the trackers and the burr. These are two disposable things, and the drapes. So the patient is charged only extra amount is about that. That comes to about, you can say, about 700 to 1,000 USD, something like that. And you asked something? Indications for robotics. Okay. Yeah. So actually the first is that one patient comes to us, we explain both the possibilities that you can do by conventional and this, advantages and downsides. Downside mainly is that $700, $800 of additional cost, which some of the insurance companies don't give, and patient has to spend from the pocket. So some patients say that we'll pay it, or some patients don't. Medical indications or clinical indications, I think more the deformed case, the more indications for robotic surgery. As far as the partial knee replacement or unicompartmental is concerned, 100% cases do robotic, because that is one area where robots have really clearly proven to be very effective. And every time, because otherwise if you see the results of partial replacement, this gained popularity and then it went down. And just with the Oxford knee, some surgeons who were doing regularly high volume cases, their results were good, but otherwise partials were failing because the accuracy of implantation was not really optimum. The instrumentation was not optimum for partials. So all partials, which are around, we do around 500 knee replacements in a month in my hospital. So it's a very high volume center. out of which about 20% now go for uni, and they are all robotic surgeries. As far as the TKR is concerned, around 50% of our patients adopt for robotic surgeries. So more deformities, the patient having more bone defects, the robots give you a better understanding. So in those cases, definitely robotic is a clinical indication for that. But now more and more patients are adopting for robotic indication.
Okay, thank you. Dr. Narendra, I have a question for you that as the starters, we are in the beginning of the joint replacement in this country. So since you are the pioneer in your country at this replacement, what kind of advice do you have for these audiences at the beginning stage of joint replacement, especially knee replacement, where giving advice and persuading a patient is very difficult at this stage for?
So I'll tell you what we have gone through. Actually, when I started practice in '93, yearly I used to do hardly 5 to 7 joint replacements. Now we are doing 500 per month, and I have seen all the journey, gone through exactly the same difficulties what you people are facing right now. And very relevant question, and very important one also. There are two things. Number one, there are patients in the community. Dr. Biruk mentioned in his speech that your longevity is going up now. So 65 is the average, in spite of your infant mortality or children mortality, trauma mortality, which is mainly in the younger age group, the mobile age group. So in spite of all these things, if your life expectancy is 65, there are going to be more and more degenerative diseases in the community and lifestyle diseases, and that is how the patient profile will be there. Now there are a lot of misconceptions. The biggest difficulty which I faced during this thing, that there were two groups. Very small number of surgeons, including myself, who were arthroplasty surgeons. Rest of the orthopedic community was non-orthopedic, this thing. And that was the first beginning, that was because the patient used to go to colleague, senior colleague, he used to say, no, the results may not be optimum, and just be happy with whatever joints you have. Some were giving just steroid injections, some were giving some, manipulation, knee belts, etc. And the patients used to carry on. Now, if the doctor himself is not convinced, then the patient doesn't get convinced. So first thing was that we, like your ESOT, in our country, we have got various organizations. We started an Arthroplasty Association in India, where we started regular meeting. Initially, it was a half-day meeting. Now it is a 3-day meeting with almost 500 arthroplasty surgeons only practicing arthroplasty in India. So I think you need to start, educating programs for your colleagues. Have an arthroplasty meeting here. So the concept of arthroplasty is, first of all, driven deep into minds of orthopedic surgeons. Number two, awareness of in the community. So what we did is that we requested the state-owned television company, which is actually government this thing, that you should invite doctors for TV talk shows, health-related talk shows, where we showed all these videos of the patients, where pre-operative gait, post-operative, just like what I showed, and explained in simple words what is the knee replacement procedure. Okay, then this was explained directly to the patient, TV audience. Now there are social medias also, you have YouTube also. So start educating the common people. They should know that there is a good treatment available for this, and there is no need to get crippled. And that is why I think two things. One, start educating your peers and your colleagues on the procedure. Start having meetings here. Anytime you require my help or involvement, I am very much keen to come here and talk. Start from basics and then go to robotics. So it should be a completely arthroplasty meeting, maybe a half day, 1 day or something like that, and community education. I think these two things, definitely there are a lot of patients in the community, and I'm sure if they are coming to India for replacement, they should come to you here. And I really like this concept of reverse medical tourism. It's very easy for a doctor to come. If you cluster cases, our team can come and help you in the initial cases. Even we are willing to install and have collaborations with centers like hospitals here.
We have 2 more talks, and Anna is angry. So we take the last one comment, then I will summarize and prepare the next talks until then. Dr. Wahar.
Is some type of comment, not question, regarding these bone healers. I think this training process is not only in Africa and Nigeria, they are doing every 6 months. a good result on that. Even in our country, there was one surgeon who did in southern area some, I think, 8 or 10 years back. He collected all bone healers, and then he told them basic 4 things. 1, no tight bandage. Second, keep elevated all injured limb. The third one is, if you split in halfway, you can keep immobile the fractured side. And then here in his study, it was published in GBJS, and then 85% of all these bone centers, they improved their way of treatment. When I was active in EO system, even with Professor Jim Harrison, we talked about these things, but as I'm get old, retired, we thought how we can collect and how we, in the process, not taking patients from the bone centers. It's simply we keep them. The fourth thing is, which type of patient can be referred to the other level? If we do these 4 things, I think the process will be less. And the other thing, what we see as working in the pediatrics unit, more victims for this treatment are the children. They are judged by their families, they are judged by the bone centers, and then they get into that. I think we have a good paper which is published. A number of patients, they lost their limbs. For that, if still at this point in that, it is good to give them this direction, and I think it can bring a lot of change. The main important, this is the way of living. If you take all the patients from the bone centers, and then bone centers are already made with the human beings. We are new to treat with a modern technique. And then the society is more trust to the bone centers than us. For that, we have to understand this point, and this is what I want to say. Thank you very much.
If I can have just one comment with the other thing that we do that's done as part of the educational event with the traditional bone setters is they come to visit the hospital and make rounds on the wards to see what kind of treatment is available. And you're right, Bahiru, it's about really preventing the preventable complications. And the preventable complications, like you said, is no more tight dressings. And if you just take that away, you're going to prevent those preventable complications, refer the open fractures and the long bone shaft fractures, and anything that's pediatric elbow, send it to someone who knows. And if you could just tackle those particular things, you'll make a dent in the what I would call the preventable complications. Thank you.
Let's summarize. Thank you. I mean, the bone setter talks, the dialogue, the technology, it's endless. You can do conversations further at lunchtime, small meetings, even later at your institutes. We saw 2 extremes, if you notice. Now even thinking about using AI when they become fellows, when they become consultants like us one day. But we have to balance the transition. There is a role that we play, how to transit from there to here. So in between, how to do the transition smoothly. For this important point Claude mentioned is, we are very few. Numbers are important. We are only 600 in the whole Ethiopia. 600 orthopedic surgeons. We can't do anything. We can't cover this population. Even we are not 1,000. That's the minimum number WHO needs is 10,000 for Ethiopia. But even we are not 1,000 even. There is a long way to go. So in between, we have to include general practitioners, nurses, midwives. I mean, home to home, we have 40,000 plus, health workers. We have to train all of this and raise a force, an army of awareness that prevents disabilities from and disasters happening from tight splints and these bamboo things. The second thing is we have to educate our trainers, our graduates, residents. Always, left and right, I shout, you have to subspecialize. Everybody here is a specialist, but we all have to differentiate according to our interests, subspecialize. Some guests that we mentioned, they come and talk, they had 3-4 fellowships. I know he did spine, I know he did fellowships for every 4 major joints in Belgium. So forget one subspecialty, you have to do 2, 3, 4. That's the way forward. And the youngsters who came here, the only message from this conference that I want you to convey is plan or education, plan or your subspecialty, if not subspecialties. Then come back, then ask about equipment, form small associations, advocate, teach, post, lecture. I enjoy always when you post something. Tashoma, Said, I can name many. You post everywhere what you did, you share. That's important. You advocate, the society then chooses between those bamboos versus the patient, the last patient we saw walking. We leave that for the society. Until then, the senior guys, let's do the transition. How to smoothly we transit from, the Westerns did this way. If you Google 15th century, 16th century, 17th century, Wageshas were there. They were there. The Sweet family from UK moved US and they were practicing there. They wrote books. Without X-rays, they functioned. They were there. They existed. But where are they now? In the developed countries. So it's not fight or dialogue that settles this. It is outshining, coming with numbers, coming with better results, coming with better function, coming with better infrastructure, coming with development. As our nation develops, we'll be like the developed countries. That time, I don't think this will be an agenda of discussion at all. With that, let's summarize. Second talk is online. I think it is so timed, we have to be precise. I would like to, so in interest of time, please humbly, they will approach you outside at breaks, at lunch. Tomorrow also, we have similar talks. Communicate with them, have dialogue, conversations. For now, let us all thank them and they can be seated. Thank you.
Logan through Zoom because he cannot be here physically. So if there are any more questions or anything, comments until that, then we can take some comments and questions while we're waiting. The role of the surgeon as a leader, because all these things you talked about, changing trauma management and everything, are multi-level, right? It's not just at the level of the hospital, but at the level of ministries and even at the level of policymakers. So what do you suggest for surgeons who are usually in the OR all the time? How should they approach the subject so that they can have a wider impact and make sure it's incorporated into health policies of their countries?
I did my orthopedic training in Canada, and Canada has what's called the CanMeds competencies. The American system has different competencies, and those CanMeds competencies, there's 7 of them. And there's a couple of, one of them is you are a leader. Obviously, the biggest competency is your knowledge, skills, and attitude. But one of them is you're a leader, okay? And that's various levels, at the level of, your hospital, your department, your program, etc. The other one is you're an advocate, and that starts with patient advocacy. So you have to be the advocate for your patient. As well. So those 7 competencies, you can look it up, it's called CanMeds, CANMEDS. And if you put that in Google, it'll take you to the Royal College of Surgeons of Canada website. It's all available for free. There's a lot of different levels of where the residency programs are supposed to be developed. But one of the two important ones that kind of get left out because you're so busy taking care of patients is the leadership ones and the advocacy ones. Now, I think the other thing where we as orthopedic surgeons do a really, let's call it a shitty job, a poor job, is that musculoskeletal health. So, you're running very busy fracture clinics and clinics overall. Sometimes there's the communication gaps as well. And I think we do a really poor job at educating our patients about musculoskeletal health, not just about their fractures, but about health to improve that. And I think that's where social media can come into play. In other countries, we help run a workshop for journalists that report on injuries. So they report on car accidents, on truck accidents, and we run a workshop to give them basically Anatomy 101, and also the impact of injuries on the population. So some of the slides that I showed, and this goes to the awareness and also some of the policy advice. And this is where I want to work in Ethiopia. We've done this in the Gambia, where we've worked with leaders, not just trauma and orthopedic surgeons, but anesthesia, police, firefighters, ambulance, to develop this integrated national trauma and injury plan. It's not it doesn't include everything, but it's very specific for trauma, for orthopedic injuries. Now, it's probably a little bit more difficult to do in Ethiopia because of the sheer size of the country, but it's doable. It's doable. Now, I have a question for you. I guess we got a little bit of time to kill, if you allow me, Ananya. So you saw those three diagnoses that we picked up, closed ankle fractures, closed femoral shaft fractures, and open tibia shaft fractures. If you were to pick the next three common orthopedic trauma injuries, diagnoses that really make up a good bulk of your daily life, which ones would those be? Anyone? Which ones would those be? What's causing you problems in your practice right now where there's so much variation from one hospital to the other, where you'd like to have some guidelines to help you out?
Supracondylar fractures of the ligaments.
In pediatrics. Okay, so tell me a little about pediatric supracondylar fractures. Now, I know you're a pediatric orthopedic surgeon, so you have a special interest, but what's the breadth of treatment that you're seeing in this country right now?
We see a lot of complications from supracondylar fractures. That's why I wanted to get this.
What kind of complications?
We see lots of deformities. We see lots of leg presentations. We see lots of bone center treatments and amputations from those injuries. So it would be good to address supracondylar fractures.
What would be, if you're developing those standards of, those clinical guidelines, what would be your recommendations in terms of the aspirational treatment? Obviously getting to the right doctor at the right time, but let's assume that you can see them within 5 days. They show up, let's call them. I mean, you'll have to figure out about the displaced and non-displaced, right? I think that's where you're going to start, type 1, type 2, type 3s. Now, what would be your recommendations for type 3s?
In a place where you have a C-arm facility.
Okay, so we'd have to figure out about, is a C-arm available or is a C-arm not available? So we'd have to account for that variability. What else?
Availability of the skills.
I'm sorry?
Availability of the skills to take care of.
Okay, availability of the training, the skills. Okay, what else?
And also availability of beds, hospital admissions.
Okay, so availability of beds to be able to hang them up in traction, possibly. Okay, good.
So my suggestion is if it's not possible to do close reductions, maybe the next best option could crossing the lateral articulation.
So a minimal open reduction? No?
It's possible. It's possible.
But
But they come very late with lots of swellings, lots of complications, and not a lot of function they do that.
so during the consensus meeting we will have in about 4 weeks, these are the exact things that we're going to be discussed. Now, Lawrence was shaking his head about open reduction, so probably that'll get left on the editing floor as well. Anyone have another diagnosis? Yes, Bahira.
Thank you very much. For us, the commonest problem what we are facing, not only us, all these sub-Saharan countries, is osteomyelitis in pediatrics.
So pediatric osteomyelitis.
Yes. And then in this case, if we have a number of patients admitted, I think 20 to 30% each time, and then normally as a treatment for this problem is the early diagnosis, and then as this is already, it's a basic principle, you drain, give antibiotics, splint, almost if you catch the problem as early as possible, you may have a 100% cure. But the problem is it's a neglected patients with the acute process will change it to chronic, and then the young surgeons, especially not orthopedic surgeon, the general surgeons, what they do when they saw a dead bone and pouring pus, the only surgery what they do, they remove that the big chunk of bone, and then there is no any supporting inside bone, which we call it involucrum, and then that patient will come a flail limb, and then at the end we have to remove that limb and then fix it, this prosthesis, or that is the case. For that, this entity of problem is a big problem. I think our young orthopedic surgeon in periphery, they are facing the same thing. As I have been working almost 6 years outside Addis and Bahar Dar, Nakamt and Asala, this is one of the common problems that we faced. Hopefully the same process is going on until everybody knows it. Thank you.
So we've got 2 pediatric diagnoses. Yes. Maybe you go for an adult diagnosis, huh?
Okay, thank you for the chance. So the next diagnosis I want to be raised maybe as a protocol or something like one is...
Let's not call it a protocol.
Yeah, just...
It's a protocol, you have to follow it.
Yeah.
Okay, let's stick to clinical guidelines, standards of care, which allow you a little bit of what I would call waffle.
Yeah, sure. So I'll go with the distal radius, especially on osteoporotic patients. So especially regarding to classify, especially the distal radius common classifications, plus also the treatment modality. So some of the surgeons prefer ORIF with, anatomical plates. The other goes with K-wire. The other goes with closed reduction and the likes. Even plus the immobilization period is also the one which is different from surgeon to surgeon. So I think I picked the distal radius fractures.
Yeah, I think that with regards to distal radial fractures, you got to be careful in terms of age and bone quality. And I can tell you that after a long, probably 5 years of my practice were just with distal radius fractures and going through back and forth, and I think some of you will appreciate this. The elderly osteoporotic distal radius fracture, you don't need a standard of care or consensus. You need just two words. Those 2 words are skillful neglect. Okay? Skillful neglect. Close reduction, you want to make sure that the hand doesn't get, you want to make sure that they have a new hand. Now there are a few indications. Okay, so open fractures, obviously you have to do something.
Fractures involving maybe the humerus. So it's common for patients to fracture their wrist and also get either a supracondylar fracture of the distal radius or a fracture of the humeral shaft. But I think that with regards to what you're proposing for elderly patients, we don't need a consensus. It's skillful neglect. Okay? But that does not mean neglect. It means skillful neglect. The younger patient with the distal fracture, distal radius fracture, I agree with you that some type of standard of care is probably required. Are we ready? Are we ready? We're ready? Okay. Thank you very much, everyone.
Thank you. Over 70 publications, and he's written many book chapters, including soft tissue infection and the AO infection manual and treatment for fracture-related infection, and the textbook of polytrauma management. So I think he's ready and online for his presentation. I would like to call upon the moderators, Dr. Elias, Dr. Johannes Yegis, apologies, and Dr. Moa to moderate these two sessions. Dr. Yegis, Dr. Elias, and Dr. Moa. Dr. Moa and Dr. Elias. Okay, maybe Dr. Ephraim or Dr. Zagana can take the spot for Dr. Elias. Ermi, are you ready? Okay, thank you.
Thank you very much for the introduction. Can you hear me well? Because I have a slight interruption in between. You can hear me? Yes, perfect. Okay. So I will share my screen and you just have to... You see the screen now?
Yes, we can see your screen. Go ahead.
Do you see the presentation now?
Not yet.
Not yet?
Yeah.
So, just
Okay, we can see it now.
you saw it?
Yeah.
Just have a technical problem here. Can you see a presentation now?
Not yet.
Very much for the invitation to talk at your annual conference. It's a great honor for me, and it's really a pity that I cannot come in person this year, because I have now a little daughter, and so time with family is rare, so that's why I could not come in person to you. I would have loved to come back to Ethiopia, because I spent already I was already twice in Ethiopia. In 2016, I had the possibility to stay 3 months in Jimma as an orthopedic trauma surgeon at the University Hospital, and there I also traveled around your wonderful country and met a lot of good friends. And then in 2019, Claude invited me to come to the AO Alliance course, and I guess and hope many of you are today also present in the audience. So I'm going to talk about fracture-related infections, and we will first start with the definition, the consensus definition that was established by the AO Foundation on fracture-related infections. We will learn about the diagnostic criteria, and then I will set up together with you a basic treatment algorithm for fracture-related infections. So, what is a fracture-related infection? So here we have an example. So that's a 50-year-old patient, distal fibula fracture that was fixed 3 weeks ago with a plate. And you can see in the proximal third the wound healed fine. Here the wound hasn't healed perfectly. There's just some light secretion. Stitches are still in. We have some slight redness. So is this an infection? I ask you. Here is a different example. Other patient. Here the patient forgot to remove the stitches, so this is 6 weeks down the line. So it was more red and was more swollen because the family doctor marked the redness 2 days ago, so it settled down without antibiotics or anything. Is this an infection, or is this just redness because the patient was walking too much and the swelling was too much? Different example. Is this an infection? So here we can see 10 weeks down the line after an ankle fracture. Here you can see the backing out of the positioning screw. So you have a contact from the outer road to the inner road. So here I ask you, is this an infection? In this example, I think most of you agree, we have 2 weeks after an ankle fracture of an old lady, pus pouring out of the wound. So this is, most of you would agree that pus pouring out of the wound is a fracture-related infection. And this is quite an easy extreme case where most of you would also agree this is a fracture-related infection. In fracture care, we had the problem in contrast to the arthroplasty surgery. So in arthroplasty surgery, for the last 2 to 3 decades, we had standardized definitions for this problem. In fracture-related infections, we haven't had a definition until 2017. So in 2016, under the umbrella of the AO Foundation, the OTA from the United States, and the European Bone and Joint Infection Society, a group of experts from around the world, not only orthopedic surgeons, also plastic surgeons, ID physicians, gathered and proposed a definition for fracture-related infection. Why is it so important to have a definition? Because only if you define a problem, you can properly diagnose it, and if you properly diagnose it, you can properly treat it. And only if you have a standardized definition, you can do standardized research worldwide and compare results and also improve medical care. So, what was the first decision of this group? The group said there should only be one single definition for all fracture-related infections. So, the group said it's arbitrary to have a subdivision, for example, like the CDC definition of surgical site infection. So just remember the examples of the distal fibula. What is here a differentiation between a superficial and deep infection when the plate is just 3 millimeters beneath the skin. So this is arbitrary. So therefore, the group said there should only be one single definition for all fracture-related infections. And then a very general term was introduced, the term fracture-related infection. The purpose was to have a term that is not related to osteosynthesis, for example, infection after fracture fixation, because as many of you also know, there are a lot of infected fractures that haven't been fixed, that have been treated conservatively. So that's why this very general term fracture-related infection was introduced. So now coming to the diagnostic criteria. So 2 levels of certainty around these diagnostic features were defined. So the criteria can be confirmatory. So if a confirmatory criterion is present, you can definitely diagnose a fracture-related infection, or there are suggestive criteria. So 5 confirmatory criteria were defined in the list of suggestive criteria. And if there are suggestive criteria, further investigations have to be undertaken to look for confirmatory criteria. These further investigation can also be a surgery with taking intraoperative samples that you finally diagnose your infection. So what are the 5 confirmatory criteria? If you have a fistula, sinus tract wound breakdown, so if you have a contact from the outer road to the bone or the implant, you can definitely diagnose a fracture-related infection. If you have purulent drainage from the wound or pus during surgical exploration, you also can definitely diagnose a fracture-related infection. Intraoperatively, we take cultures, deep tissue samples, and preferably 3 or best 5 deep tissue samples for microbiology and histopathology. And if we can detect the same pathogen in at least 2 out of these 3 or 5 tissue samples, we can definitely diagnose a fracture-related infection. Later I will highlight why it's important that's 2. Then, if we see the microorganisms by histopathological examination using specific staining techniques, for example, gram staining for gram-positive cocci, we can also definitely diagnose a fracture-related infection. And last but not least, it's also histopathological examination. If the histopathologist sees an acute inflammatory response that's represented by more than 5 neutrophil polymorphs per power field, you can also definitely diagnose a fracture-related infection. So these are the 5 confirmatory criteria, and over the next minutes we will pick them also up in the diagnostic algorithm. And here is a list of suggestive criteria. Suggestive criteria mean if a suggestive criterion is present, you cannot definitely diagnose a fracture-related infection, but they can be, of course, highly suggestive. Local signs, so local redness, swelling, warmth. Swelling, for example, can also caused by other situations than infections. But especially if it's combined with other suggestive factors, for example, elevated serum inflammatory markers, it can be very highly suggestive. Then radiographic signs. Every fracture non-union is a suspected fracture-related infection until proven the contrary. A very nice study from Scotland showed that of all long bone non-unions, an underlying infection is the cause while the fracture did not heal. So if you have a non-union, look for an infection and exclude the fracture-related infection. The next, if you take 3 or 5 deep tissue samples, and if you detect a pathogen only in one single deep tissue culture, it's only suggestive. And why? It's because you do not know it's a contamination that can take place from sampling intraoperatively up to handling in the surgery, up to handling in the laboratory. So that's why it's important that you have multiple samples. And if you have the same pathogen in two samples, a contamination with the same pathogen is very, very rare. But if you have it only in, if you only prove a pathogen in one sample, then it's good to have the histopathology. If the histopathology, then this pathogen is very likely the disease-causing pathogen. As already said, serum inflammatory markers, they can be highly suggestive, but elevated serum diagnostic algorithm, because it's difficult to treat a disease that hasn't been properly diagnosed. So when you go back to your hospitals, establish together with your colleagues a multidisciplinary diagnostic and treatment strategy and try to follow a diagnostic algorithm. So we will go through this very basic algorithm, and these algorithms includes the confirmatory signs, the suggestive signs, and it's divided in preoperatively, intraoperatively, and postoperatively. So let's start off. We have a suspected fracture-related infection. So it's very important that we capture a very detailed medical history. Try to get access to the old X-rays, the X-rays of the previous fracture fixation. You can learn a lot from that. Perform a detailed clinical examination with thermic infection stages. Laboratory examination, serum inflammatory marker, and imaging should be performed. So, what are, as a repetition, the clinical confirmatory signs we can see preoperatively? It's if we have sinus tract fistula wound breakdown, as seen here, we can see the plate, so we can mirror ourselves in the plate. So that's why we call it the mirror sign. You can see yourself mirroring in the plate. Then we can definitely already here diagnose a fracture-related infection. Again, the image you have seen already, if pus is pouring out of the wound, you can also definitely diagnose a fracture-related infection. What are the suggestive signs again? So, clinical signs, redness, swelling, warmth, systemic signs. Again, as mentioned, radiographic signs. Just keep in mind, every non-union is a suspected FRI until proven contrary. Elevated serum inflammatory markers, persistent new onset of wound drainage, and the joint infusion and articular fractures. So if you have fracture-related infection, or in certain cases, for example, you have a slight redness and just slightly elevated serum inflammatory markers, it's no harm just to wait. Tell the patient, we wait some days, you come back in some days, and we have a look again. Rest the days, and maybe it has settled, or it has got worse, and then we know we have to go to surgery. Now, just for the serum inflammatory markers, so from the consensus group, we performed a study and also systematic analysis, systematic review and meta-analysis, and we found out that serum inflammatory markers are not suitable to rule out or diagnose fracture-related infections because, as I told you, there are many other causes that are causative for elevated serum inflammatory markers. So, now coming preoperatively to the imaging modalities. Why do we perform imaging modalities in the diagnostic workup of fracture-related infections? First of all, I want to know what is my fracture healing doing? Is my osteosynthetic construct stable, yes or no? So herefore, the working horse is plain X-ray. Then, sometimes imaging modalities can help me to establish whether there is an infection, yes or no. Here I need a CT scan, MRI, or nuclear imaging techniques. And the last question for the imaging modalities is helpful, but also if these are not available, the ultrasound is helpful preoperatively to give you an impression of the soft tissue extent of the infection for a better preoperative plan. So, serial normal X-ray radiograph, these are the first method of choice and also my always preferred method of choice, and often you do not need a CT scan or anything else, because here you can have a very, very good overview of the anatomy. You can compare it to previous X-rays that are available. You can see the bone quality, you can see the vitality. Is the bone healing, or do I have dead bone fragments? Can I see an implant loosening or failure? And X-rays are quite easy accessible, and they are also suitable for follow-up examinations. If available, and if you want to look more in detail for preoperative planning, an X-ray and CT scan gives you information on the detailed bone structure. You get some more detailed information. What is the vitality of a fragment doing? For example, here we see this fragment. You see no turnover. This fragment looks sharp as if the fracture was yesterday. So very likely this fragment is dead, because here is no bone turnover happening. We can see periostal bone formation. We may see necrotic bone or sequestra, and a detailed view on the implant loosening. So what are evidences for infection? As mentioned, it's a cortical bone reaction. It's a sequestration. Here you can see nicely a sequestra. So this is a piece of bone that is sharp-ended and looks like as if the fracture would have been yesterday. Bone ends that are alive, round off like here. You can see this piece is very likely alive, but this piece is sclerotic and not remodeling, so this is very likely a dead bone or fragment. You can see intraosseous fistula or abscess formation in the extension soft tissues. So we perform, because we have it available, but I know it's very rare in your setting, an MRI scan. You may be able to use an ultrasound, as mentioned, to see the soft tissue involvement. Here we have an intramedullary infection. You can see the intramedullary manifestation and the soft tissue fistula. However, the MRI has significant limitations in fracture-related infections. As you can see here, we have metal scarring artifacts, and also in the early post-operative phase, so within the first 6 weeks post-operatively, an edema might mimic an infection, so also there interpretability is limited. So now we have done the pre-operative diagnostics, so now we go to surgery. So what are our confirmatory signs in surgery? So if we have passed in surgery, we can also definitely diagnose a fracture-related infection. So now we are coming to a very important part. Intraoperatively, we take samples. So ideally, if possible, 5 representative deep tissue samples for microbiology and histopathology. So try to take these samples from the side where you assume the infection, around the bone, around the implant. Do the sampling during the initial part of the operation to minimize the risk of a contamination during surgery. And then, if possible, try to avoid antibiotics 10 to 14 days prior surgery. Of course, if you have a septic patient, this is not possible. But in most FRI cases, the patient is not septic. So you can keep the patient off the antibiotics, because it's more important that you know the pathogen you want to fight. If you do not detect the pathogen by the samples, you do not know your enemy to fight, and then you have to give a very broad spectrum antibiotic that is causing a lot of harm and costs also a lot of money. So you have to optimize the sampling. Don't take samples from sinus tracts, because the sinus tracts communicate with the outer environment, so then you can also take a swab or a sample from the trousers or the bed of the patient, so this is not representative. Take deep samples. Try during sampling to avoid manipulation in the wound, because your fingers are not as sterile as your instruments, so that's why take it with clean instruments, and then establish together with your operation theater personnel and lab personnel a protocol that the samples are transported to the lab as fast as possible to allow best analysis. So now we send the samples to bacteriology, and now we are post-operative. So I mentioned before, if we detect the same pathogen in more than 2 deep tissue samples, we can definitely diagnose a fracture-related infection. What does it mean, the same pathogen? Here is an example. This result gives us, we took 5 samples and we grew a staph epi in 4 samples. But it's the same pathogen. You have to look at the resistance pattern. It's not only staph epi, it has to be the same resistant pattern. If it's exactly the same pathogen in at least 2 tissue samples, so here in 3, we can definitely diagnose a fracture-related infection. We know that this is the disease-causing pathogen. So this staph epi. Again, histopathology, the gram staining, and the presence of an acute inflammatory response. So, suggestive signs, as mentioned before, if we detect the pathogen only in 1 single deep tissue culture, we do not know, is it a contaminant or is it an invasive infection? Then important to take in parallel samples for histopathology if you have the ability to do so. Because if you have a pathogen only in 1 culture and the histopathology is negative, then it's very likely a contaminant. But if the histopathology is positive, it's very likely the invasive pathogen. So I would like to summarize. This is the very basic treatment algorithm. I will provide you the literature for that. And that's not a one-man show for an orthopedic surgeon. You need to establish a strategy with your OR personnel, with your lab personnel, with your radiographer, with your ID physicians. So just for the key recommendations in the end, if you have a non-union, always think of a fracture-related infections. The presence of confirmatory signs of FRI should prompt the treating multidisciplinary medical team to proceed with developing a treatment strategy. The presence of suggestive signs of FRI should prompt the treating medical team to further investigate the probability of an FRI, and that can also be intraoperative sampling. The only clinical confirmatory signs are sinus tract wound breakdown or purulent drainage. And just remember, if you have elevated serum inflammatory markers, they can be highly suggestive if combined with other factors, but then also other causes are positive for elevated serum inflammatory markers. I thank you very, very much again for the invitation, and greetings from Basel in Switzerland, and I'm looking forward to the discussion. Do you want me to proceed with the next presentation, or
yes,
question answer now?
No, it's better to continue with the second talk, and then we'll have a discussion after that. Could you make it to continue, Mario?
Sorry, I couldn't understand you.
He can continue with the second presentation. Can you hear me?
Just, I will call close, just a second.
Oh, okay. You are not listening, that means, yeah. No. We can continue to the second presentation. Michael Saman. Mario, we can continue to the second one.
So I repeat, I give the next talk?
Yes. Yes.
Just give me the hand raise. Okay,
Yeah,
perfect,
yeah.
because I cannot hear you. Next talk. Okay, very good. Thank you. Okay. So, very good. I'm set up again. You can see my presentation? Yes? Very good. Okay. So, now we learned how to diagnose a fracture-related infection, and now we're talking about treating a fracture-related infection, how we can establish a treatment plan. So, I will introduce you to the new classification for fracture-related infections, because we will learn about the most important criteria we need to know for treatment, and these are incorporated in the new FRI classification. And then we will go through a very basic treatment algorithm. I will also provide you the manuscript for that. And then we will learn how to apply the FRI classification, so the new AO FRI classification to the treatment algorithm. So this is the classification. I will go with you through in detail in the next minutes. And first, what are the most important factors to guide treatment in fracture-related infections? So what I have to know to set up a treatment plan. So I need to know what is the stability of my osteosynthetic construct. So do I have a stable osteosynthesis, yes or no? Is the fracture reduction acceptable, yes or no? Next point, is the bone dead or alive? Preoperative X-ray, as we learned, can give very good hints, but the definitive answer you will get intraoperatively when you see if the bone is dead or alive. Bone like porcelain is dead. Bone that wrinkles and reacts, that is vital. So we need to know about the vitality of the bone. Can I access the implant? So can I debride the surface of the implant and reduce the bacterial load around the implant without removing it? So for example, in intramedullary nails, you cannot reduce the bacterial load around the implant without removing it. What's the soft tissue quality? Do I have a soft tissue envelope that's contributing to bone healing and infection eradication? Next, what about the risk factors of the patient? And last but not least, what about the disease-causing pathogen? So let's go to the first factor, the most important factor, the fracture situation. So is the bone showing a healing tendency? Is it vital or is it dead with a sequestrum? Or do I even have a bone defect? Is the osteosynthetic construct stable or unstable as shown? And can I debride the implant as mentioned? And these, the consensus group summarized in the F situation. All these factors, it's in the fracture situation. And another important factor for treatment are the risk factors, the systemic risk factors of the patient. Because a study showed if the patient has significant risk factors, this is associated with a high risk of failure. And there are many risk factors that can be optimized preoperatively or during the treatment phase so that the patient will result in a better treatment outcome. And the last important factor is the impairment of the soft tissue. So do I have a soft tissue envelope that's contributing to bone healing and infection treatment? Or do I have a scarred soft tissue envelope and do I need to reconstruct it? So here, for example, the same example you have seen already. I have a soft tissue envelope that's stressed, but I may be possible after removal of the plate to close the soft tissue envelope. If you have this problem over the proximal tibia, you will not be able to close it tension-free. So you need a local flap, like a gastro flap, to close this. More complicated, if you have this big defect over the distal lower leg, you may need help from a plastic surgeon that can do a tissue-free tissue transfer and to cover this defect. So the consensus group summarized these factors, so the fracture situation, the risk factors, and the impairments of the soft tissues in the new FRI classification that's going to be published the next weeks. So here you can see these are the factors. It's the fracture, the risk factors, and the impairment of the soft tissues. And these are the stages. Stage 1 is the simplest stage. Then up here it's increasing severity, and up to stage number 4. And stage number 5, these are stages in which you can perform reconstructive procedures because the patient is too unfit, the defect is too big, or the patient declines surgery. So let's have a look at the F variable. So the F variable, that's the F1, is the healed situation, and from the F2, F3, F4, it's an unhealed situation. We will go to it more in detail later. So here, there's the R variable, the R1, so the patients are fit for surgery. In the R2 and 3, you have comorbidities, but no end organ damage. R4, you have severe systemic comorbidities with an end organ damage, and in the R5, the patient is unfit for surgery. Now coming to the soft tissues, if you have an I1 situation, you have a robust soft tissue, so you have vital soft tissue. You can directly close them after your debridement. The I2 situation, you have fragile soft tissues. So you can close them, but these are the patients you advise better to stay in bed for some days that the soft tissue swelling settles and the wounds heal. The I3 situations are the situations which need a soft tissue coverage, but which you can cover with a local tissue transfer. In contrast, the I4 are the ones you need a free tissue transfer with the help of a plastic surgeon. And last but not least, the I5, again, is the palliative situation in which a soft tissue reconstruction is not possible because the defect is too big. So here again, you see an overview of the classification, and then, for example, you can rate the case. You can say, I have an F3 situation, so the fracture is not healed with a poor healing potential. I will come later to what this means. With an R1, so it's a fit patient, but an I4 situation, so he needs a tissue transfer. And if you classify the situation with this coding that's like the AO fracture classification, everybody knows what you are talking about. So now coming to the treatment. So what are the main principles of surgical FRI treatment? So it's debridement and implant removal, on one hand side, it's debridement and implant retention, or it's debridement and implant exchange. So you can exchange in one or multiple stages, and you can exchange to an internal or external device. And what are the antibiotic regimens? So it's infection eradication, that's where we aim at mostly, but in some cases it's not possible, and then we have to go for infection suppression. This is a very, very simple treatment algorithm the consensus group published, and I will also provide you the literature for that, where you can see this algorithm. And I will go with you in the next minutes through this very basic algorithm. So this algorithm includes the surgical principles, removal, retention, exchange, and the antimicrobial regimens with eradication and suppression. So coming now back to the F situation. In the F situation, we will apply to the algorithm. So F1, the fracture is here. And from F2 on, the fracture is not here. The F2 is a fracture that's not healed, but has a good healing potential. In contrast, the F3 has a poor healing potential. And that's the most difficult discrimination between these two factors, and the most important one. And I will spend some minutes to explain to you later the differentiation. To diagnose an F4 is again quite simple, because this is a major bone defect that needs reconstructive procedures. And again, F5, the fracture is not healed, but no reconstruction is possible because the defect is too big. So let's start with our algorithm. So first question, is the fracture healed? If the fracture is healed, we have an F1 situation. So we can remove the implant and debride the implants. If the fracture is not healed, we have an F2, 3, or 4 situation. And now we come to the most difficult question in the decision-making process of treating fracture-related infections. It's the question, can I retain an implant, or do I have to exchange the implant? So what are the situations in which I can retain the implant? Because in certain situations it's tempting to retain an implant. Just for an example, you have fixed a complex proximal tibia fracture with 2 plates from medial and lateral 2 weeks ago, and now you have an infection. If you have to remove the 2 plates, and each plate has, for example, 10 screws, you have 20 screw holes, and if you remove them and put in new screw holes, then you have 40 screw holes in total, and you have a lot of devitalized bone. So in certain situations, a DAIR procedure might be maybe way better because you cause less damage, and not your whole fracture fixation again falls apart. So what are the situations in which you can retain the implant? So you can retain the implant if you have a good healing potential. What does it mean? So if the fracture reduction is acceptable, if my osteosynthetic construct is stable, if the bone is alive, and if I can have a good infection control potential, I will shortly highlight this, we may be able to retain the implant. So this is a situation where we have a good potential for progression of healing. So it's easier in which situations should we not do an implant retention. So we should not do it if the osteosynthetic construct is unstable. Instability is further supporting infection. If you have an unstable osteosynthetic construct, it's not worth keeping this implant. You have to exchange it. If you have that bone under the implant, you can only debride it if you remove the implant. So it's also not worth keeping this implant. If the fracture reduction is not acceptable, this is of course from case to case different. What is acceptable? This is also your decision as orthopedic surgeon. But if you have a not acceptable fracture reduction, like in this case, it's not worth keeping this implant. And now coming to the important part here, what does it mean, no infection control potential? So their procedure can only work if you can reduce the bacterial load around your implant. In place, you clean the surface of the plate and reduce the bacterial load. But in intramedullary nails, you cannot reduce the bacterial load without exchanging the implants. So there are good studies out now that show if you perform a Dare procedure in infected intramedullary nails, you will have high rates of failure of around 40%. So to summarize, a Dare procedure may be possible if your construct is stable, reduction is good, the bone is alive, and you can debride the implant surface. And keep in mind, intramedullary nails are, if you dare them, they are associated with a high risk of failure. So in all the other situations in which the fracture is not healed and you don't have a good healing potential, you have an F3 or an F4 situation, then we ask ourselves, major bone defect, yes or no? So if yes, it's an F4, that's quite simple. So what is the F3 situation? These are the situations that are in which one of the following contract indications for Dare procedure is present. So I have dead fracture ends, the reduction is not acceptable, or the fixation is unstable, or I have a bad healing potential in this situation. So it's not worth keeping an implant if one of these situations is positive. If we exchange the implant, we can exchange to an internal or an external device. And if we have a major bone defect, so what does it mean? So a major segmental bone defect means you need reconstructive techniques to reconstruct the bone and the functionality, and this can be in one stage or multiple stages. I don't cover this in this talk because this would be a separate topic for a talk. So this is the summary for the F ovarian. So last but not least, what is the F5 situation? So the F5 situation is if we have a massive bone loss and the reconstruction is not possible, or the patient is declining surgery, or we have complex morbidities that have a high risk of failure, we have a F5 situation, but maybe we can optimize the patient. Maybe we can optimize factors that we can reduce it to an F4 situation. If not, if we end up with an F5 situation, so a palliative situation, the only available options are an amputation or conservative, like a consistent draining fistula, for example. So now, just some words to the risk factors of the patient. Perform, as I mentioned in my previous talk, a detailed medical history. Look at the risk factors and the comorbidities of the patient and try to optimize them. Try to optimize them ideally before surgery, but you can also optimize them at any time during your treatment process. Look at the diabetes, look at other systemic comorbidities that lead to better healing of the patient. Then look at the soft tissue envelope and the impairments of the soft tissue envelope, as I mentioned, and you may need a specialist. In the end, just some words to the antimicrobial treatment. What do I need to know as an orthopedic surgeon for the basic principles of antimicrobial treatment? So you need to know, after my revision surgery, is an implant present, yes or no? Do I have a super drug-resistant infection where I have no antibiotic drugs, and do I have a difficult-to-treat infection? I will explain you what this means. So you only need to remember these three things for the treatment algorithm. So what does difficult to treat mean? If you have, after your revision surgery, an internal implant present, a curative approach is only effective when you have biofilm active antibiotic drugs. And these are rifampicin for gram-positive bacteria and trinolones for gram-negative bacteria. So if you have, after your revision surgery, an internal implant present, and you have a gram-positive, so Staph aureus infection, and it's resistant against rifampicin, or if patient cannot take rifampicin because he has allergy or something else, or it's not available, you have a difficult to treat infection. The same accounts for the gram-negative bacteria that are resistant against the trinolones. So let's go back to our algorithm and look at the antimicrobial strategies. So the F1 situation, we debrided, removed the implant, so we have no implant, so we do not have to take care if it's difficult to treat pathogen. We don't need to treat a biofilm. So if you have no implant, we call it an osteomyelitis antimicrobial treatment. So in general, the duration for an osteomyelitis is 6 weeks in the adult. So we give IV antibiotics until the wounds are dry. As soon as the wounds are dry and have available oral options, we switch to oral antibiotics. And if no implant is present, in general, 6 weeks. If we do an implant retention, so we keep the same implant, we debride it, we have to ask ourselves, is the infection difficult to treat? If no, we can eradicate the infection, so we have to give rifampicin and the gram-positive combined with another drug, and for in total 3 months. But if we have a difficult to treat infection, we have to give suppressive antibiotics until the fracture is healed. And then we stop the antibiotics and see what happens. If the infections flare up again, you can remove the implant because the fracture is already healed. What is when you perform an implant exchange? Here we ask ourselves the question again, do we exchange to an internal device? If we exchange to an internal device, it's the same as the retention. Difficult to treat infection, yes or no? If we exchange to an external device, it's much easier. I don't need to look at difficult to treat pathogen. It's the same as if I have an implant removal because I have no internal device. I treat for 6 months. So here is the summary for the surgical and antimicrobial treatment. Just in the end, to summarize, FRI treatment as diagnostic, it's not a one-man show. You need a team. You need a team in the OR, physiotherapist, nursing, internal medicine, ID physician, and if available, also a plastic surgeon. And the patient has to be a basic part of this difficult treatment plan. To summarize, the most important factors in treating fracture-related infections is the fracture situation with, is the bone healing, is the bone dead or alive, is the osteosynthetic construct stable, do I have a perfect environment for healing, yes or no, do I have a bone defect, can I surgically control the infection, look at your risk factors and look at your soft tissue envelope. So do I have a soft tissue envelope that is contributing to bone healing and infection eradication? So do I have a robust soft tissue envelope on top of my bone that is transporting the systemic antibiotic and the host immune cells to the scene? Or do I need to reconstruct the soft tissues because there's a fistula or they are so scarred up? This is the classification. I will also provide you then in the handout with the treatment algorithm. And again, thank you very much for listening.
Thank you very much.
Ephraim, do you want me to continue with the last talk? Just give me a hand raise like this, or this when you want discussion.
No, I think we'll stop here. We're running late for lunch, so. But we're gonna have questions for you, so.
Very good.
Okay, good. So we're gonna take like 2-3 questions because we're running out of time before lunch break. So anybody who has questions?
Thank you very much. You hear me? Is someone? Okay, I have 2 questions. The first one is, this is a very serious problem for orthopedic surgeon infection. Who should take care of this problem? In our country, the senior person and the young. Normally we push these problems to the young trainees. That is correct or not? The second thing is that you face drug-resistant infection. I think some literatures, they say, there is a multiple problems coming in this area where the infection is resistant to drug. You didn't mention that. What we have to do in this case? Thank you very much.
Okay, I just repeat that I correctly understood because I had a slight echo. So the first question was, who should treat the fracture-related infections? The youngest or the most experienced? That's correct?
Yes.
Yeah. So we have in our team, we have a dedicated center for musculoskeletal infections in our hospital. So we are one of the 2 most experienced surgeons in that field, and we treat them all. Because in fracture-related infections, even so that seem to be the simple ones, you have one chance to get it right. And you have to do it right the first time. Because if you don't get it the first time, it's getting more and more complex every time. So, because we all know the situation, you try to exchange a plate and it fails, then you get loss of bone stock and your soft tissues scar more and more up. So you need the most experienced surgeon for this field to treat the fracture-related infections. And that's what my colleague Martin Klaus, I do all day. And the next question, thank you very much, but this is on the undrug resistance. So what to do if we have resistant bacteria? So it's very difficult if you have to find with your ID physician if there are options to treat the infection, any options. And then together with the ID physician you have to set up then the treatment plan. It can be that also the non-drug resistant infections you have to treat with a suppressive therapy until the fracture is healed. Because then you can stop the antibiotics, and once the infection is flaring up again, you have the advantage and remove the implant, because then the fracture is healed. Did this answer your question?
Yes, thank you very much. We're gonna take one more question from the audience, and we're gonna hear some from our moderators before we leave. Any more questions from the audience?
Thank you very much. So my question is for FRIs, usually, if there is a bone gap, we usually use cement as a carrier. But apart from that, we just sprinkle the antibiotics. So I would like to know your suggestions on the use of carriers and what cheap carriers are there at our disposal.
Sorry, I couldn't get what What is it?
So your suggestions on the use of carriers for local antibiotic delivery instead of just sprinkling it in.
So you need local antibiotics?
Yeah, carriers for local antibiotics delivery.
Carriers?
Yeah.
Carriers, okay. So if you have available local anti-carriers, you may be able to give them, the question is, here you have to differentiate. You have carriers that are resorbable and non-resorbable carriers. So non-resorbable carriers, for example, PMA, if you use them, you may only use them if you have a staged approach, because this is not resolvable, this carrier, and you have to remove it, because if you leave it in, you have the problem that this may cause resistance, because once, after around 3-4 weeks, antibiotic concentration rate goes down the carrier, and then this may be a risk factor for recurrent infections. So, areas I use PMA cement area. If I do a staged procedure, for example, I have an intramedullary nail infection, I can make a rod, a nail out of PMA, I place it intramedullary, and I treat it, and then after several weeks, I remove it and exchange it to a new nail, for example. Or if I have a bone defect and you do a muscular technique, you can also place a PMA cement block, but here it's the same. You come back, remove the spacer, and then fill the gap with the bone graft. So just to remember, if you have a non-resolvable carrier, you have to remove the carrier again. And then there are resolvable carriers, but they are quite expensive and also have side effects. So we don't use them very often because there are some ceramics, but they cause leakage, so we only use them rarely. Did this answer your question?
Yes. Yes, thank you.
Okay, thank you, Dr. Mario from Basel, for the nice presentation you shared with us. So, as we know, this topic is very sensitive, and ESOT this year topic is fracture-related infection. It indicates that infections after surgery are sensitive, and all based on our local setup and based on the principles we have discussed, we have to deal with these topics. So we have seen what are the principles, definition, and the criteria to say there is an infection or no, means the two main confirmatory criteria and suggestive criteria. These are very important to deal with fracture-related infection. And the other thing is regarding the treatment. Already we have seen the classification and the factors which should be analyzed in treating fracture. So thank you for the presentation and thank you for the audience.
Thank you very much.
Okay, thank you, Dr. Mario.
Yes.
Thank you, Dr. Mario, and our moderators. You can go to your seats. Let's give them a round of applause for a fantastic moderation. So, a few messages for you before we leave for lunch. You have received two different cards. One card says Alan Elfing, and the other says the Marathon Hall. So they're both downstairs outside of this building on your right. They're side by side. So those of you with a card that says Alam, Elfing, you should go to that hall. And those of you with a card that says Marathon Hall, you should go to the Marathon Hall, okay? The names are written at the top of the doors, so you won't miss it. But I would like for you to slow down and first let those with the Alam Elfing exit first, and then those with the Marathon card can follow. And this conference